So there are three ways to reconstruct the outer ear that we have used over time. One is you can make a prosthesis that is made of plastic that will stick on the ear with a glue that can look like the other side. There's a very specialized skill to make that, but it can sometimes look very good. You usually have to have one for the winter time and one for the summertime when the skin gets a little darker with sunshine. The second technique is to use a rib graft when the child is about 6 or 7. That surgery has its first stage. Usually there are 3 stages. And the rib graft is taken from the chest, it's carved into an ear, then it's put in place. Usually 3 separate surgeries are required to make the lobule, to make the tragus, and then a last surgery is to do the ear canal surgery. Now, since you now know that development is important to get hearing in early, you will understand why the rib graft is not my favorite, because usually a child is 12 or 13 years old before we can do an ear canal with the rib graft surgery. Most of what we do now is a material called porous polyethylene. Sometimes you will hear it called MedPor, and there are several companies that make these devices. And it's a material that we use to do other reconstructions. Heart valves, hips, other implants, and the body does not reject the material. So it is a good man-made material to make the ear from. I would add that I think in future times, we will be able to take cartilage from the child and then grow lots of cartilage and then print an ear that looks like a normal ear. We've tried that now in several adult patients, and the technology is not ready yet. I think it will probably be maybe 10 years before that's completely worked out. But that, I think, is what the future will hold. Now, the minimum age for reconstruction for the porous polyethylene is 3 years of age. That's also the time when we can do the hearing canal. So as you know, with the combined surgery, they both can happen at the same time. Sometimes patients will do the ear canal first and then 6 months or more later do the outer ear. So when you compare the rib versus the porous polyethylene, the advantage that the rib has is it is a natural tissue. And natural tissue is always better than man-made tissue. But it is close. The rib is a little better, and sometimes the porous polyethylene will have a reaction. The skin will have some exposure, and sometimes we have to do a small surgery to cover it afterwards. I'll show you that. But the advantage of the porous polyethylene is you can do it earlier for the child. You can do it in one single surgery. I think it actually looks more natural than the rib. The rib graft, when you look from the side, looks normal, but it's hard to get projection. So the rib will be flat against the head, and the porous polyethylene will be out like the other side. Now, if you see a child here that we've done surgery, and if you're able to touch that ear, the porous polyethylene is hard. It's rigid, it doesn't bend. So the ear feels a little different, but it looks like a normal ear. I think it looks the most normal. And then the cost of the porous polyethylene, because we can do that in a single surgery, is less than the rib that has to have 3 separate surgeries. So this is a patient who is in the operating room, and you see his right ear, you can see in the red lines, that is an artery that comes up in front of the ear, and it supplies a membrane that is between the skin and the skull. That membrane is what we use to cover the prosthesis. And when we do that, the skin goes on top of that membrane. We can't put the skin directly on the implant, because it's the blood supply that keeps the skin healing and keeps the skin alive. Now, this is the patient who is about 2.5 weeks after surgery. You see that there's a little bruising as the skin is healing. You see the sponge is still in the ear canal. This will come out at about 3 weeks after surgery. And you can see the earlobe has a more natural color than the skin graft. As the ear heals by about 6 months or 9 months, the skin of the earlobe and the cheek and the ear are the same color. Okay, so let's talk about the things we have to do in the operating room to reconstruct the outer ear. So I want you to be able to know what a patient goes through with this procedure. The first thing we have to do is to choose the implant, the shape, and the size. The second is that we need to cover the ear with the membrane. I'll show you pictures of that. And then we need skin to cover the ear on the front, and also skin to cover the ear on the back. And you saw earlier that we need a third skin graft, which goes in the ear canal to cover the eardrum and the canal itself. We need to reconstruct the earlobe, and this is called the tragus in the front. So the tragus, as you look at someone, if you don't have one on one side, it causes your eye to go to that. So we like to have those the same so that it looks good. It also covers the ear canal partially. So there is some protection for the ear canal. And then the last thing we have to do is we have to secure the outer ear and the ear canal so that they stay aligned. We don't want those to switch or you can have a problem. So let's talk about each of those. Now, this graft is a graft that was, actually this research was done a long time ago, about 30 years ago, where the outer ear was measured at each age. And if you look at the graft, you see, for example, at 5 years of age, the ear is 90% adult size. So we know that if you have an ear reconstruction at 5 years of age, we need to make the prosthesis 10% bigger than the other ear. Because the normal ear will continue to grow a little, so that when the child is an adult, the two will be the same size. So depending on what age you do the surgery, for example, at 3 years, we have to add 12%. If we do the surgery at 8 years, we have to add 7%. So that way we know that things will be good when the child is grown. Okay, now, the implant that we have used before is made by a company called Matrix, and it is an omnipore implant. It's made of porous polyethylene. It's a single piece, and there are left and right, and we have multiple sizes, so we can select the size that we need. And the technique for putting this in is to put the tissue flap over the top of that. Now, one of the problems that I have seen recently with this implant is that we have seen a number of patients who have had a fracture of the implant. So you have the surgery, things go well, the ear looks good, you get back home, and as you can see in these pictures, there's an area where the implant breaks or folds in or has a problem. So that concerns me. And the plastic surgeons that we have worked with have seen about 15% of their patients who have had this problem. That's too much. So what we've done is that we have, as I told you, our philosophy to find a better way is, I think what we have needed is a new implant. Now, over the last 4 months, 5 months, I've been working with the company to create an implant which I think will stop the problem that we're having with the fracture. So this is in my office, and I have a drill, and I was able to carve and create implants that are sturdier and that are more natural looking than what we've used before. So that implant comes in several sizes, as you can see here, and it's the first of these implants where we can create an ear canal and an outer ear together. This company has been making implants previously, and their implants have been very secure. They haven't had the fracture problem. And they also have had very good, what we call biocompatibility, which means the body accepts that implant, and it's been very secure. So today, you are the first ones to know of a prosthesis that is new, that will be available in December, that is called the Roberson Combined Atresia Microtia prosthesis. When we have our consultation, I have one of the old implants, and I have the new implant, so you can see them, and you'll be able to see the difference. So this implant has several advantages, I believe, compared to what we have used before. It is stronger, it's a little flexible. It's still not as flexible as a normal ear, but it moves a little. And it also has a way that the implant does not pull back and get close to the head. It holds itself out a bit. So I think we're going to see this will be an improvement. It's made by a different company, but I'm excited about this. I think it will help us with some of the problems that we have seen. Now, let's talk about the tissue flap. So, as I mentioned to you, the artery goes up in front of the ear, and if you feel in yourself, you will feel the artery just in front of your ear. And that artery goes up and supplies a flap that's under the skin. You see in this diagram that the flap that we take is about that large. We work under the skin, and we bring the flap down from under the skin, and then we wrap that around the implant. And this diagram will show you how that works. There's the implant going in, and here's the flap put around the implant. Then we trim it and sew it around the implant. And then we cover the ear with the skin graft. So for this ear to heal correctly, that flap has to be healthy, it has to supply a good blood supply to the skin graft, and it has to be flexible. So I also have a new way to raise or to create that flap. Excuse me. In the last few years, the surgeons that I used to work with used electrical dissection. And sometimes that can damage the blood vessels in the flap. So I now have a new machine that I've designed to lift that flap and to preserve those blood vessels, which I think you will see, and it's showing that already, that we're not seeing a problem with the skin as often as we've seen before. Now, where does that skin come from? There are 3 pieces. One is from the scalp for the ear canal. I showed you that earlier. And then for the front of the ear, I like to remove the skin from the surface of the small ear and take that off and then put that back on the front. Because the color match is extremely good. It looks the same as the cheek. The back of the ear, we take a skin graft where the leg meets the body and put that in position behind. Okay. Here is a patient who's back for their second ear, and you see on the left side a scar that is where we took the skin for the back of the ear. We put that in a place so when they're wearing shorts or a bathing suit that it is covered. You can't see it. Now, we like to take a long time to cover the entire ear with the skin graft. And it takes us probably close to 200 sutures to get everything just right for the coverage. It is, at first, the ear looks bruised and it looks swollen. So when we take the dressings off the first time, the color is not healed yet. It's swollen, so it's thick, and it looks bruised. So as the ear heals, then the skin goes to normal color, and the skin begins to shrink into the implant and to cover it as that comes down around the implant. It takes almost a year for all of that to happen. But by about 3 months, 90% of that healing has happened and the ear looks really very close to normal. One thing that you have to be careful of is after we make the outer ear, the surface of that ear doesn't have the normal sensation that a normal ear does. So for example, if you're if you're in a cold place, you're wearing a hat, and you put that on your ear, sometimes, as you know, if it pushes on the ear after a while, it starts to hurt. And a child may not feel that on the reconstructed ear, so you have to be careful to put a soft hat if you're going to ski or go outside and it's very cold, so that we don't cause any damage to the skin over the ear. Okay, so this is a patient. You can see the earlobe in the bottom. You can see all of the sutures with the skin graft in the front that was taken off of the original ear and put back on. And then you see where the suture line is with the skin graft behind. And I like to put those suture lines where they look natural, so that you have a curve right where you should have a curve. So that the ear, as it heals, you don't tend to see that with your eye. Now, what about the earlobe? The earlobe is always present, but it's usually in the wrong position. So usually the earlobe is flipped up, but it's still attached in the right place. So we are able to save it and to use it. We like to leave it attached in the very front because it has its own blood supply, and that will help the ear to heal well. One question I get is, can you have an ear piercing after the surgery? And usually you can. It depends a little on how much earlobe you have. If it's very, very small, sometimes it's hard to pierce. But if it's a good size, then you can pierce that, not right at first, usually 3 or 4 months later. But it is possible for girls to wear earrings, for example, after you do that. Okay, so here's an example. This is an ear, a left ear, and you see the artery that we have marked here that we're going to use for the flap. There's another one here. This part of the ear is cartilage, and then this is the earlobe. So that we like to save. So what we do is that we mark that in the operating room, and then we'll remove, or we'll make an incision on part of the earlobe, and then we'll bring that backwards into the proper position. So you can see that we rotate this point back to here. So this, all of this is the earlobe just turned in a different position. Okay. Now, the tragus, which is the piece in front here, can be reconstructed in 2 different ways. One is that when we take the cartilage of the small ear out, then I can carve from the cartilage a shield which will be buried under the skin and will form the tragus. That's one way. The second way is that our new prosthesis has a tragus built into it. Now, I can remove that if it's not quite the right shape for a patient. But depending on what looks best and functions the best, then I'll make that decision in the operating room. So here, you can see a right ear. You see the earlobe has been rotated into position. And in the front, you see this suture. So that suture is holding a piece of cartilage, which is under the skin, in position to make the tragus. That suture stays about 4 weeks. We take it out, and then the tragus remains. Okay. Now, and lastly, what we like to see is a very secure connection between the outer ear and the ear canal. When we first started doing the combined surgeries, we saw after a period of time that the outer ear with gravity will start to come down sometimes. And sometimes it can come down enough that it actually can block the ear canal. So what I started to do is to use a piece of tissue that's against the bone, and I would create a tag of tissue that I can wrap around the implant and sew in place. That tissue is very tough. So when it heals, it holds the ear so the ear doesn't move down. One of the differences between the combined surgery and the separate surgery is that with the separate surgery, I can't preserve that piece of tissue. So the combined surgery has less of a chance of the ear actually coming down later. That's the only difference I see between the two surgeries. The hearing's the same, the ear canal is the same, the use of the middle ear bone prostheses are the same, but the outer ear is more stable because of that technique with the combined surgery. Okay. So, lastly, at the area where the ear canal opens, we have found that we need to make that ear canal slightly bigger than the other side. And the reason is when a child ages, the normal ear, if you have a normal on one side, the atresia, the normal ear canal will grow. But the atresia side doesn't. It tends to stay the same. So we make the atresia a little bigger, so when you're an adult, the ears are the same size and the ear canals are the same size. And here is an example of an ear where the tissue flap was not used. This was early. And you can see, as we move this, that the ear has moved down and has started to cover the ear canal. So an ear canal will not stay healthy if we don't keep air circulating through it. So this required a revision surgery where we had to lift the implant to open the ear canal again. But with the new tissue flap, that's rare for us to see that problem now. Now in the operating room, we put a mold over the ears, and I suture it in. Children will be children, and afterwards it's your hardest job is to keep them from running and jumping and playing. And that dressing, they can't get off. So it's very secure for them. That dressing stays on for about 10 days to 2 weeks, and then we take it off. You can see in this picture that there are sutures that hold this material in place. It's an exciting day to see the new ear when we take it off. But what I do is in the operating room, I take pictures of what the ear looks like so you can see it. Because your family wants to see it, your friends want to see it, the child wants to see it. So you'll have those photos of what it looks like. And then that comes off before you leave. So the complications that we have seen, I mentioned the first one, the fracture, the implant fracture. I think that that one will be rare with the new implant. So I think that one is good. The most common thing that we see is that the skin over the implant heals over most of it, but there might be a small area where the skin graft doesn't heal correctly, and we have to do a second surgery to cover that area. Almost always we know that in the first few weeks after surgery, while you're in the United States with us. The different technique I mentioned to you to preserve the flap, I think will make a difference with that. So that's what we're working on now. Also, the nerve that controls the face on that side, the nerve that goes to the front of above the eyebrow, comes very close to the artery that we lift the flap. And sometimes you'll see that there is a weakness of that side. When the child tries to raise the eyebrow, it doesn't raise like the other side. Almost always that will come back to normal, but it sometimes can take up to a year for that to happen. About 4% of the time we'll see a weakness in that branch of the facial nerve. The implant, as I mentioned, can become displaced, it can move down, that's a complication. And sometimes when we are lifting the flap, especially with the old way of doing it, with the electrical dissection, we will see the hair follicles can be injured, and there'll be an area where we lose some hair. Now, again, most of the time that will come back, but since we've been doing this newer technique, we haven't had any hair loss. So I think that is another area that we can see improvement. And lastly is the artery that goes in front of the ear. There are times when the artery is in the wrong position. So the artery can sometimes be directly over where I need to make the ear canal. And it's very delicate, but I can take the artery and move the artery out of position so we can make an ear canal and still use the flap. But we have seen some patients who have had an injury to that vessel. Frequently, or fortunately it's very rare, but that's on the list as well. Now, this is a patient, of one of our plastic surgeons we used to work with, and on the bottom, you see right here, there's a new skin graft. So what happened is that the ear healed well, except for that junction between the earlobe and the bottom part of the flap. So there was some skin that started to turn dark. If we leave it, then that can get infected and can cause us to lose the implant. So another surgery was done about 3 weeks after the first one while you're still with us. And a different tissue flap was brought in and a new skin graft is put in place. So that one is the most common thing that we see as a problem with the outer ear. Now let's talk a little bit about results. I'll show you some pictures. This is a young girl in the operating room who has a grade 3 ear. You see the blood vessel that's marked in the red. So we've removed some hair on that side, which we need to do. And you can see in the front that this is the tube, the breathing tube, where the machine is breathing for her. And then these electrodes are monitors for the facial nerve. So if we are near the facial nerve, or if we are irritating it in any way, it will cause a twitch in the muscle. The machine picks up the twitch and then it sounds an alarm for us. So it's an added safety measure to prevent an injury to the facial nerve. I think the worst thing that we could have happen is to have a surgery and then injure the facial nerve so there's no movement on that side. And around the world, that happens in about 1% of cases. And so far, in the 4,000 or so of these that I've done, I haven't had that happen. It's always possible, but I hope we can avoid that forever. But the facial nerve monitor adds safety to us. I don't think that monitor is available here in Kazakhstan. It's a relatively new piece of equipment that I work with a company called Medtronic to be able to produce, and I think it adds a good amount of safety. This is the ear from the patient that you just saw in the operating room. Here's another patient, same thing, but a right ear. You see the blood vessel has 3 branches in this case. Okay, and there is his ear before we leave the operating room. This is a young boy who is about 3.5 weeks after surgery. I have removed the packing from his ear. There's some cotton in the ear canal. And you can see that the earlobe is a normal color, but the skin graft is bruised, as it frequently is. And as that heals over the next 2 weeks or so, that redness will go away. Okay. Now this patient, I'm going to show you pictures through the whole portion of surgery. And this is a patient we operated on in August of this year. So this is in the operating room before we start. You see where the ear is going to be positioned. You see the artery here. Again, these are the facial nerve monitors. And then this is the breathing tube that you see. So that's 7:45 or 8 o'clock in the morning. And this is about 1:30 in the afternoon. So we now have an ear in position, a tragus, the earlobe has been rotated in, the 2 skin grafts are in place. Okay? We put the mold on, put the wrap on before we wake the child up, and then 15 days later in the clinic, you see that we are removing the mold and the sutures. So now the mold is off. You see that we're cleaning the ear. There's still a sponge in the ear canal here. That sponge has to stay in place to put pressure against the skin graft on the bone, because if we hold the skin graft against the bone, then the body heals into it and the blood supply is established. And then 3 weeks after the surgery, we can take the sponge out and the skin inside the ear canal is alive. Now this is about 1 week later. It's our second clinic visit, and you can see that the sponge is now out. So you can see down the ear canal. You can see also the ear is a little more swollen, and I think a little more bruised. I'll go back here to show you. So that's where he was on day 15. This is day 21. Okay. And this is day 29, right before he's going to go home. You can see that we're having them put ointments on the outside, which is something you will do at home after you head home. And he went back home, I think the day following this, on day 30. And there's still some sutures in place, but the sutures that we use come out by themselves, so you don't have to have them taken out. They dissolve and then fall out on their own. And here's his getting ready to leave. My staff, they fall in love with these little children, and they make for them a cape that's like Spider-Man, and a mask. And on the back, it says superhero, and they spell it like Hear, H-E-A-R. So we always give that to them on the last visit, because we want them to remember us without being happy that they knew us. So we have a good time with that one. And then this is a picture on day 57 that the parent sent me when he's back home. And you see that the ear is starting to, the swelling's starting to go down, and the ear is starting to get the crevices and the normal look of a regular ear as it goes. Okay, here's another one that's about 6 months after. Picture sent from home. Okay, and here's a young man who had bilateral atresia microtia. That is, he's here for his second ear, so that's his left one. And then his right one, as you can see here, he's hearing without any hearing device or BAHA, and we're getting ready to do the second ear for him. So this one is a good one to look at in terms of the hearing, this graph. So what I did is I looked at our score on the CT scan, and then our hearing tests that were done later. Your first hearing test, by the way, is about 5 months after surgery, because the hearing continues to improve to about 5 months and then it will stabilize. So we found that in patients who had an 8, a 9, or a 10 score, that the hearing came back into the normal range in 80% of patients. And in a score of 6 or 7, it came back into the normal range in 67% of patients. Now, almost everyone gets improved hearing from the surgery. And even at its best result, the reconstructed hearing is not as good as normal hearing, but it can be very close. So for example, you can use the phone on both sides, but if the child uses the phone and listens in both sides, they'll say it's a little louder in the normal ear. You can hear whispers. You can, if heaven forbid, if you lost this ear, you would be able to function. But the hearing in a well reconstructed ear is about 90% of what a completely normal ear is. Now, the other question people ask is there a difference in hearing between patients who have a normal outer ear and have a canal, patients who have 2 separate surgeries, they have the ear canal first and then the outer ear, people who have the combined surgery, or people who have a rib graft. So we looked back at our results and we found that in the rib graft, the hearing was just a little worse than when we used the porous polyethylene, but it's exactly the same between the different surgeries. So I don't think you can choose which surgery based on the hearing. I think it's more on the outer ear portion. So I mentioned protecting the ear in very cold weather and avoiding pressure on that. But cleaning of the ear is something that is very important. Haley and I will get emails from around the world all the time, and it says, my ear is infected, what do I do? And our first question is, when did you have the ear cleaned last? And usually they'll say, well, I think it was 18 months ago. The problem is that the skin will build up in the ear canal, and then the fungus or bacteria can get in, and then it begins to attack the normal skin. And you'll get an infection or a blockage so that the hearing is not good. Now, I think you know her. I don't see her, but is Dr. Medrulova here somewhere? Maybe she's outside. So we have a surgeon who works here in Almaty, who we are working with, who is cleaning the ears for us. I think that's very important that you have somebody locally who knows what they're doing, is comfortable with it, and it has an open line of communication with us. So I'm very happy to work with her, and that's going to be important, I think, for time goes by. The way I think of the cleaning of the ear, it's almost like cleaning the teeth. It's like you have to go to have your teeth cleaned sometimes. The teeth take longer than the ear. It takes about 5 minutes or 10 minutes. And as I mentioned, it's usually in the first, well, when you go home, we ask you to have it cleaned the first time about 6 or 8 weeks after you're here. Then the next time is about 3 months after that. Some people we can begin to space it out. And some people we have to keep it closer together. And Dr. Medrulova will be able to decide. The average is once or twice a year to clean the ear. Once the ear is cleaned the first time, then you can get the ear wet. You can swim, you can have a shower, you can go in a sauna, you can do anything where the ear gets water in it. But until it's cleaned the first time, it's not a good idea to get the ear wet down the ear canal. Okay. This young man had surgery with us, and his family likes to ski in Canada. So he wears a helmet, which is good. But what we did is his parents took a knife, and inside the helmet they removed some of the padding so that when he wears the helmet, it's not putting pressure on his new ear. And he's done very well with that, and that's a good solution for that. So let's review, and then we'll take some more questions. So this is, if your brain is organized in a flow diagram, this is your slide. So the first thing we do is the CT scan. And if the patient is a score of 6 to 10, then we recommend an ear canal. If the patient is a score of 1 to 5, then usually we will recommend either a bone conduction implanted device or an ear canal and a hearing aid. Okay? If you decide to have the ear canal, then there are 3 ways to do that. One is to have the rib graft and then the canal afterwards. Number 2 is to have the ear canal and then the PPE afterwards. Or number 3 is to do the combined surgery. Now, one of the questions that I always get at these conferences, what would you do if this was your child? And if I had a child with atresia and microtia, the ideal would be in the 3rd or 4th year, I would do the combined atresia microtia. I think that the surgical results are good enough now that they are as good or better than any other technique. And I really like the option too of a child not having to have several surgeries. When I first started doing this, the rib graft surgery was what we did, almost always. And by the time the child was 12 or 13 or 14, they had 4 or sometimes 5 surgeries. I felt like the child was almost traumatized because they had had so much work done. When we do the surgery in that age and the patient came back to me, they would always say, my reconstructed ear. When we do the combined surgery, and when we do it early, in the 3rd or 4th year, patients come back to me and say, my ear. I think that's a big difference. Because I think it means that the child feels like that's part of them. I think most of the time they don't really remember a lot of the surgery and a lot of the care. And I think that's better for a child than having several surgeries over time. So for my own family, that's what I would choose, and that's why I would choose that. There are some patients who ask me, can we do the ear canal and then wait to see if there is a new outer ear material? It's a good question. The answer is yes. We could wait 5 years or 10 years between an ear canal and the outer ear if we wanted to. It's hard for me to know exactly when that will be available, but I think I'm very confident it's going to be more than 5 years away. So for my own child, I would do a surgery to get the hearing in so the brain development goes along. And I think what we'll see is that the patients who have had the PPE, the rib or the material that we use, I think it will be actually fairly easy to change that to a cartilage ear if they want. When we have the fractures that I showed you earlier, the way we fix that is that we make an incision in the ear and we open the skin, we put the new implant and we close it. It's much easier than I feared it would be at first. And I think we will be able to do that if cartilage becomes available. So your children are 3 or 4 or 5, right? We have 80 years to think about them living with this ear. And I think it's very wise to think, what does the future hold and what could we do as the future goes? We have to make the best decision for them right now. And you'll see many doctors who go, oh, don't worry, wait till they're 13 or wait till they're old enough until they can decide for themselves. And I would encourage you to say that's not the way, because the hearing and the brain development they will miss is something you can't get back. So I think this is a question that you almost have to make for your child. I think that you will, when they're 25 or 30, there'll be a whole different solution. But the thing that we all can do for our children now is to give them the best that's available at this one point. And the way we do this now, I don't think that we will burn any bridge. I think that we will still be able to use future technology if we want to do that and change to it. Now, that's a hard question. If you had a good-looking ear that wasn't having any problems, would you change it? I don't know yet. But I think that is something that we will see as time goes by. Let me show you a few more resources, and then I'll take some questions. So, my daughter Haley and I wrote a book about Microtia and Microtia. It's designed for parents. You've all had this situation. You have your child, you see something wrong with their ear, the people who help you deliver go, I don't really know what that is, and then you try to figure out what to do. And it's very frustrating because the information you get sometimes is wrong, or sometimes the information is conflicting. Different people tell you different things. So this book is designed for you to understand the whole process. It's written in English. It's been translated into 7 different languages. It's in Russian. It's not translated in Kazakh yet, but it's in Russian. So if you want that, read that. That's a good thing. This is also a good book for a grandparent or someone else in your family who says, what are you doing and what does this have to do with? You can give them this book and say, read this book. That's one process. This is our Instagram account. We have a number of things that are posted there. If you follow Instagram, so you can see some of the patients and some of the things that we put together. Let you get a photo of that if you want it. Okay. And then the website that we have has, it's translated into different languages, Russian being one I think would work here. And on that website is a section where there are videos. And we have a wonderful new use of artificial intelligence that we can put the video into this module and it will translate that into any language like that. So you will hear a voice over the lectures that I give speaking to you. And we are recording this lecture today with the both, I think, the English and the Russian feed. So if you want to look at it again, or if you want to share that with someone, then we will send a link to you or be posted on the website here. Okay, now, one housekeeping issue is that we have set for everyone here about 15 minutes in an appointment. We have a lot of people to see, which I'm very excited about in the next 3 days. We will meet you on level M, which is, I think, 2 floors up, and directly across from the elevator is the executive conference room. So we'll be seeing you in the conference room. If you wait outside the doors, when it's your turn, we'll have a volunteer who will then come and take you inside. I have a number of questions to ask you. For example, the Here Maps store, we'll try to get as much of that information together, and then you'll leave with a plan. If you have all that information already, you'll know whether surgery is a good idea and what to do. If you don't, then we'll give you ways to send that information to us. And Haley and I will read that, and then we will get back to you to get you the answers that you need. As I say, don't worry if you don't have everything today. If you do, great, we'll do it. But if you don't, we'll keep working with you to get that information to you. Okay, now let's do questions